Assalamu alaikum wa rahmatullahi wa barakatuh. We are restarting our sessions. We are going to have the final gastrointestinal session now. We will enjoy our talk again with Prof. Marc Benninga, who gave us a nice talk yesterday about intestinal pseudo-obstruction. So welcome, Prof. Benninga again.
Thank you very much again. Good morning, everybody. After the very fruitful discussion about hepatology, I wonder how we do with this topic, functional defecation disorders in the first 3 years of life. I'd like to discuss with you what is actually normal in defecation, what's abnormal, other causes of constipation you might be aware of, treatment and follow-up. I don't know if you are, if you recognize this little slide. It's about the meconium production in the first years of, in the first days of life. And why I put on this slide, I don't know why, but the slide is bigger than what I can see on the screen. But on the x-axis, you appreciate the time of meconium production. And as you can see that in the first, so the very young children have delayed meconium in contrast to the full-term, yes, there it is, with the full-term babies. And this is very important to realize. And so the mean meconium production during the first weeks of life in the very young children is different from those who are born full-term. So this is important with respect to the meconium production. And as you, of course, know, the delayed passage of meconium after 24 hours is well known for Hirschsprung's disease and cystic fibrosis. Another very important slide is, and that is what I always discuss with my patients, is the number of normal stools in children. Because, as you probably know, defecation does not need to be daily. And this slide shows you that, again, from the first days of life, there is a decrease in defecation frequency compared to those children who are older of age. And from the age of 3 years of age, the defecation frequency in children is as in adults, which means 3 times per week to 3 times per day. But again, this slide is important to discuss with your patients. And of course, there's a difference between those children who were breastfed or formula-fed within the first 3 months, because as you can appreciate from this slide, children on breastfeeding have more frequent and more softer stools compared to those who have formula feeding. If you want to explain to the parents the amount of stools, the consistency of stools, but also the color of stools, we in the past made this picture for you, which was published in Journal of Pediatrics, and we followed the defecation of 1,000 babies on neonatal intensive care units and on the normal dorms, and these were the differences with respect to amount, consistency and color. And sometimes it's very helpful for parents to look at these pictures and to be aware that the color, amount and consistency differs between babies. You have all read, of course, the specific issue of gastroenterology in which the new Rome 4 criteria were described, and then there's this little book, especially for pediatricians who are involved in these very common disorders in childhood. And with respect to the young children, we made this list of different entities: infant regurgitation, infant rumination syndrome, cyclic vomiting syndrome, infant colic, functional diarrhea, infant dyschezia, and functional constipation. And I will discuss G6 and G7 today with you. First of all, I always have to show this slide, what I'm talking about. This is about, of course, functional constipation, and this must include 2 out of 6 of the following symptoms, and in most children this is hard, painful and infrequent stools. As you know, the prevalence of constipation is everywhere. There's a beautiful paper from Saudi Arabia in my remembrance with Carlo Di Lorenzo, which showed that the prevalence of constipation is everywhere the same. And that's strange because the cultural habits, the diet habits is different if you compare the different countries. So what is the exact cause of constipation? And this slide shows you how difficult it is to exactly rate the etiology of the causes of constipation. And of course, in the youngest age group, behavior must play the most important role. These children experience painful defecation, and based on these painful defecations, these children tend to withhold stools. And this is the most common cause we acknowledge in children with constipation, even in the first year of life. And then there are many other symptoms or causes for constipation, stress. We now look in our own population for physical abuse, sexual abuse, emotional deprivation, and we are certain that a higher number than we know now has caused the problems of defecation. More difficulty is genetics. Until now there is no gene identified which is associated with functional constipation, and there is one paper about the microbiome which shows no difference between those children with constipation and healthy controls. And as I showed you yesterday, it's difficult to find abnormalities in the nerves, the muscles and the interstitial cells of Cajal in children with constipation. So again, this slide stresses that there are many causes for constipation, but the exact cause is unknown, and in the young children, behavior is probably the most evident cause for constipation. The differential diagnosis, you know, it's functional in more than 90% of the cases. In some children, we can find a change from breast to formula feeding or cow's milk allergy. There are some rare causes for constipation, as you know, anatomical or neurological disorders, and some other causes where you look for with respect to the meconium production. So this is important as well to acknowledge the difference between Hirschsprung's disease and constipation, because only with symptomatology we are able to suspect children of Hirschsprung's disease, as I already suggested, delayed meconium production, and there is of course enterocolitis, which to my surprise I've never seen in children with functional constipation. How do we diagnose this? Well, this is simple in my opinion, because if you suspect a child of having Hirschsprung's disease, you should always do a rectal suction biopsy. This is an old paper by our group, which shows that indeed the sensitivity and the specificity is by far the highest if you compare it to the contrast anema and the anal rectal manometry. So please, if you suspect an infant of having Hirschsprung's disease, perform a rectal suction biopsy. Anal achalasia, which is also quite new in the diagnosis of constipation, was described by Sam Nurko from the United States. I show you here a normal anal rectal manometry. The catheter is placed in the sphincter complex, and after air insufflation, it will elicit a normal anal rectal inhibitory reflex. You have to keep this in mind. What's wrong with internal anal sphincter achalasia? These children again present with severe constipation and do not respond on the normal laxatives. Well, you suspect Hirschsprung's disease, so as I showed you, you perform a rectal suction biopsy and you find a ganglion cell. So then you have to keep in mind then anal rectal achalasia might be the other diagnosis, so you perform an anal rectal manometry. Here you can see you inflate the rectal balloon with air, but as appreciated here on the red line, there's no relaxation of the internal sphincter. So if you see on a biopsy normal ganglion cells without a relaxing sphincter, we make the diagnosis of internal anal sphincter achalasia. And these children are very well helped by botulinum toxin. And as you know, it's completely uncertain how long the response will be. In some cases it will be a month, but in other cases we were able to successfully treat these children for 7 months. And I suggest if the response is only 1 or 2 weeks, then it's too painful, too expensive to perform another injection with botulinum toxin. On this cow you will find the world map, And the question is cow's milk allergy related to constipation as well? And this is a debate among many, many pediatricians, because you are aware of the beautiful study performed by Iacono in the late 90s, which showed that indeed, if you withdraw cow's milk from the diet, there is an enormous response on constipation in this group of children. 70% respond effectively, and there was no response on cow's milk. And to my surprise in this paper, within 3 days, the anal fissures and the painful defecation disappeared on soy milk. And then he was able to correlate the effect of this trial with a higher incidence of rhinitis, dermatitis, and bronchospasm, and immunological testing and rectal biopsy. Osvaldo Borelli, now from Great Ormond Street, he used to be in Italy, indeed showed that the anal rectal reflex was different in those children with cow's milk related chronic constipation compared to those who did not. And he also found this in the biopsies of these children. So there is a suggestion in these two papers that there is a relation between food allergy and chronic constipation. But there are also other types of research, and also from Italy, from Anna Maria Staiano's group. They did a population-based study in more than 5,000 children, and they collected 69 children with constipation and compared them with 69 controls. Here are the data from these children, and there were not many differences between patients and controls with respect to breastfeeding and induction of cow's milk and family history of atopy. And then they compared these 12 children with constipation and allergy to 13 controls. And to their surprise, they had no reaction, no response at all in these children. So this paper actually questions the relation in a population-based study, the relation between constipation and allergy. But I will discuss this difficult topic later on in the presentation. So what are the most common causes of constipation? I showed you Hirschsprung's disease, cystic fibrosis, anal achalasia, but of course, a functional defecation disorder is the most common symptom of constipation, and infant dyschezia. What is infant dyschezia? Well, in your daily practice, you recognize it very easily because those infants are young, they stress, they at least 10 minutes strain and cry before or during or successful passage of soft stools, and they have no other health problems. So this is very, very common. We have no clue what it is, but of course, if you write a manuscript, you have to come up with the hypothesis. So this is where we came up with failure to coordinate increased intra-abdominal pressure with relaxation of the pelvic floor, even in very young children. What do you do about it? Well, it's very easy. You reassure the parents, you educate them that the symptoms will disappear, and be patient. I don't know how it is in your countries. In Holland, nobody's patient. It has to be resolved within the next day. But this is not true for this, because we show that even in babies, the symptoms might go on until 9 months of age. Don't use a thermometer. Don't use laxative. Be patient. So this is a very nice old paper by Vera Loening-Bauch, which showed that hard bowel movements and pain during defecation are the most common symptoms of constipation in the young children, and not bowel frequency. Also, these children withhold stools based on these hard and painful bowel movements. Probably you can't read this slide, and this is what I intended to do, but in GPGN 2014, you can read everything about diagnosis, symptomatology, and treatment of constipation. But I will go through a very easy scheme in children younger than 1 year. So these children have difficult defecation. Then, of course, you have to look for warning signs like meconium production, abdominal distension, as we discussed yesterday, neurodevelopmental delay, and anatomical abnormalities. If there is yes, then I think you should refer this patient to a specialty consultation. If not, then we have to ask about breastfeeding, of course, because we do know that in infants who receive breastfeeding, the defecation frequency might be different and might be only once every 10 days. If yes, then reassure, give some education. If not, then you might ask in medical history for the specific formula feeding, if they combined the powder in a good order with the milk. So we have to think in those cases also about functional constipation. If you improve with just simple formula feeding changes, then nothing is wrong. But if not, then please, 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 please start with laxative as soon as possible. Don't use a wait-and-see policy. So you can either start with lactulose, or if you're in your country is available polyethylene glycol. We do use polyethylene glycol from day one. And of course, if you suspect the child having allergy, then it might be helpful to change to a hydrolyzed formula. If there's improvement, then you're a very good doctor, but please follow these children carefully. If not, then you might suggest to refer the patient again to a specialty consultation. So this simple scheme shows you that you have to look for warning signs, change formula if necessary, but the most important information from this slide is start laxatives as soon as possible. And why is this? Well, this paper shows you that if you use a wait-and-see policy, this is difficult, the red dot, and if you use a wait-and-see policy, that's the black line, and you don't use laxatives, then the chance that your child will improve or resolve of the constipation symptoms is only 30 to 50%. Whereas if you start immediately with a laxative, the chance that the symptoms disappear are more than 80%. So in summary, constipation, as you know, is very, very prevalent, and even in the first years of life, and probably based on a functional cause, because an organic cause is very rare, and you would specifically look for the warning signs. And again, as I stressed, early treatment of constipation with a laxative benefits prognosis. And then this is my last slide. In 1.5 months' time, there is this very, very nice 8th European Pediatric Motility Meeting in the UK. And if you're interested in motility, everything is there. All the people from all over the world with the newest and latest information. Thank you very much for your attention.
Thank you very much, Professor Marc. You're finishing on time, and even before 2 minutes more. Okay, so next lecture will be by Dr. Ahmed Al-Adsani. He's a pediatric gastroenterologist from King Fahd University Hospital in Al-Khobar, and he will give us a talk about biological agent in IBD.
Bismillahirrahmanirrahim. Thank you very much, Mr. Chairman, and would like to thank the organizing committee for their kind invitation. We'll talk about one of the really hot topics in pediatric GI, biological therapy for pediatric inflammatory bowel disease. This is the point we'll try to highlight it in the coming few minutes. So, as we know that IBD is multifactorial disorder that characterized by chronic relapsing intestinal inflammation with increasing incidence worldwide, and pediatric cases represent almost 1/4 of the IBD registered with difficult and more aggressive presentation, and not just in the typical presentation, sometimes will present in uncharacterized atypical presentation like affecting linear growth and other extraintestinal manifestation. Since biological therapy have been introduced, there was major modification happen for the treatment strategy as well as the disease course. In pediatrics, we have the infliximab and adalimumab, which was the only so far approved for usage in pediatric IBD, with some usage of other medications off-label following the adult the experience and adult literature. So, since last SBGAN guideline for management of IBD, it was clearly stated the role of biological therapy in the management of Crohn's disease as well as ulcerative colitis, since it was clearly stated for Crohn's disease that anti-TNF therapy will be recommended for induction and maintenance of the patient who have chronic active Crohn's disease, prior optimized immunomodulator therapy, as well as in case of steroid refractory disease. It can be also used as first choice for the patient who have perianal fistula. For the ulcerative colitis, it was stated that infliximab should be considered for the treatment of the children who have persistently active despite of conventional therapy. Also, infliximab can be used as a first choice as a bridge for thiopurine before starting, for a chance of 4 to 8 months, then start thiopurine. Regarding the adalimumab, it should be used only after lost the response or intolerance of the infliximab. So regarding infliximab, it was the first licensed anti-TNF agent in pediatrics. It is chimeric human mouse immunoglobulin. It was being studied over the last almost 11 years, which showed good effect and in inducing and maintenance remission in pediatric IBD in general. The main study in the pediatric, which is multi-center open-label study, which is REACH trial, they try to evaluate the efficacy of safety for the induction dose of infliximab. It was tested 112 patients for the induction and later on extended for 1 year evaluation to evaluate 2 regimen of the maintenance therapy, whether Q8 weeks versus Q12 weeks. So by the end of the induction, it showed clinical remission in 88%, and clinical remission was seen in 60% of the cases, while clinical response in 88%. After 1 year of therapy, it was showed clearly that clinical remission has been achieved in, if we can see the diagram on the left side, it will show that, this one, it will show that clinical remission has been achieved in 55% of the patient after 54 weeks of evaluation, while clinical response achieved in 63% of the patient. This is in the patient who followed the regimen of Q8 weeks. By evaluating the patient who have perianal fistula, it did show that 41% of the patient who they showed some response by after 2 weeks of starting therapy, and after 1 year, almost 70% of the patient have complete resolution of the perianal fistula. By extending the trial for 3 years, it did show that almost 80% of the patient continue to have minimal to no disease activity, and also it did show that infliximab was superior treatment protocol compared to the other immunomodulator and conventional therapy. In terms of the growth and linear growth, it was clearly demonstrate significant improvement in the height score compared to minus 1.5 Z-score at the baseline, it was improved to 0.5 after 54 weeks of follow-up. And this improvement believe that related to anti-TNF effect on osteoblast and coupling bone formation. So one of the challenge in infliximab is antibodies formation, which can be considered one of the main cause for secondary loss of response. It was shown that, that maintaining high trough level of infliximab can decrease the chance of antibodies formation and predict as improvement of the drug effectiveness. Accordingly, dose escalation and shortening of the administration interval between infusion can give a higher trough level and accordingly maintain the good effectiveness. One of the study which was released last year by Dr. Korika et al., he did systemic review for biological therapy in pediatric IBD in general, and this is he studied the literature which was released after, which was published after releasing of the latest SBGAN guideline. So from the studies which was look at the effect of infliximab effect in cases of Crohn's disease, he can conclude that infliximab is effective in Crohn's disease patient in both short and long term. And the dose intensification and increased frequency of infusion can often be necessary to achieve the sustained durable remission. Also, he showed that both of linear growth improvement as well as CRP decrease were the main two related factor to the efficacy of the infliximab. And so far, there is no good data supporting infliximab usage in the very early onset of Crohn's disease below than 6 years. For ulcerative colitis, infliximab was approved in pediatrics age group since 2011, and unlike the condition in the Crohn's disease, the cases little bit or relatively limited data we have as experience of ulcerative of infliximab in ulcerative colitis. This is one of the big study. It's a prospective multi-center study. It studied the severe pediatric ulcerative colitis. They looked to 112 patients who have severe ulcerative colitis. Almost 37 patients or more than a third of them, they were in steroid failure and required infliximab. And it did show in the short response, it was seen in more than 76% of the patients who require infliximab, while 55% they maintain long-term response and remaining free colectomy. On the other hand, it did show that the patients who were having shorter duration of the disease or newly onset of the disease, they showed better response in terms of the infliximab effect. Another prospective study done by Himes et al., they looked to the outcome following infliximab therapy in ulcerative colitis. They studied 332 patients who have severe ulcerative colitis required admission to the hospital. 50 of them required infliximab, At the end, it did show almost similar result, that the likelihood of avoiding colectomy at 2 years was 61%, and if the patient continued to have continuous maintenance therapy of infliximab, the percentage will be raised up to 74%. In terms of the systemic review done by Corica et al., it did show that infliximab have been used in both acute and chronic active ulcerative colitis in pediatrics, and it did prove effective in pediatric ulcerative colitis. Some of the studies did show that infliximab decreased the colectomy risk during the therapy. However, not all the studies gave the same result. So in summary, infliximab is an effective treatment option for both pediatric Crohn's as well as ulcerative colitis. So far, it is approved for equal or more than 6 years of age, and the dose will be administered as induction dose at 0, 2, and then 6 weeks, then followed by maintenance therapy, Q8 weeks. The dose will be 5 milligram per kg, but that it can be intensified up to 10 milligram per kg, and the frequency can decrease up to 6 to 4 weeks to every 4 weeks. Trough level and anti-drug antibodies not commonly monitored, but it was considered that it might improve the efficacy of the therapy. Adalimumab, which is fully humanized anti-TNF alpha antagonist, it was initially used as second-line therapy of biological therapy for infliximab failure, although nowadays it is can be used as first choice in case of Crohn's disease. It did show it did show effective in induction and maintaining remission in patients who have loss of response or intolerant to infliximab, as well as the patient who have never used infliximab. So the main study examined the efficacy and the safety of adalimumab on the short-term post-induction, as well as on the long-term up to 1 year. They evaluate the patient after finishing the induction, while the patient given the dose according to his weight. If it is more than 40 kilo, they will receive the dose of 160 milligram at 0 time, and then 80 milligram at week 2. And if it is less than 40 kilo, they were given 80 milligram in the 0 time and 40 milligram at week 2, and then they will be blindly randomized to 2 regimen, high dose versus low dose of maintenance therapy. So after 1 year of the treatment, it did show that if we can see the graph D, it will show that clinical remission was achieved in 33% of the general population of the study, while clinical response achieved in almost 41%. When they look to the patient who received infliximab or not received infliximab from the population of the study, interestingly, it was seen that the patient who has never started infliximab, they showed better result of adalimumab response, while 45% they get remission, compared to only 19% who was on infliximab before. So they demonstrate that adalimumab was well tolerated and response to induction was seen in 82% of the patient, and more than 50% of maintaining response at 6-month and 12-month follow-up. When they looked to the patient who have perianal fistula, the total was 36 patients. 11 patients get complete closure by the end of the year. By extending the study to evaluate the efficacy and the safety for up to 240 weeks, it showed there was 100 patients continued from Imagine Trial 1 to Imagine Trial 2, and it did show the continuous remission and response over the time. So out of the 100 patients enrolled in the Imagine 2, there were 41% achieve remission. And by the end of the 5th year, almost 63% of the patients who were required corticosteroid at the baseline, they became corticosteroid-free. Thank you. So adalimumab treatment was observed as well as like what observed in infliximab. It lead to improve the growth velocity and normalization, and there was no safety signal have been identified up to 5 years of evaluation. 2 minutes more. So for the systemic review, it did confirm almost similar what we got from the Imagine trial. This is the dose. Adalimumab in the ulcerative colitis, it was stated it doesn't have role unless we exhaust the infliximab usage in that cases. So a few studies have demonstrated adalimumab efficacy in ulcerative colitis pediatrics after infliximab failure, and it looks promising, although require more and large pediatric population studies. So what infliximab versus adalimumab, what should we use? Actually, there is no randomized control trial compared both, but if we look to the main trial applied for REACH and Imagine in pediatrics, it did show that 55% of the patients who were on Q8 weeks remission, maintenance therapy of infliximab showed free remission, while 45% of the patients who have infliximab naive were in remission. And when we look to the perianal fistula, as we saw earlier, that for infliximab arm, almost 70% of the patients have complete resolution by 1 year, compared to adalimumab, which is almost 33%. So this is adult evaluation for adalimumab versus infliximab. It did show almost the
your time is finished.
I will take 1 minute.
You have to conclude.
خلاص. Biosimilar, it is recently approved by European Medical Agency for usage, but it did show it is almost identical amino acid sequences comparable to other biological. So far we have biosimilar for Remicade CTB13. There is not much evidence in pediatrics. SBGAN did recommend that if the patient doing well with his biological treatment, then shouldn't be switched to biosimilar. Some issue about the safety, I have to skip, sorry. So by conclusion, the use of anti-TNF agent has transformed the way in which we care of pediatric patients with IBD. It has resulted not only improve the disease control, but also patient growth and quality of the life. Although that anti-TNF drug carry the potential for serious adverse event, the overall pediatric patient seems to be safe and so far well tolerated. The literature data have demonstrated that anti-TNF agents are better than immunomodulator to maintain remission and achieve mucosal healing. The use of appropriate scheduled treatment protocol can keep balance and in favor of reward over the risk. New categories of biological drugs like vedolizumab or certolizumab and other agents did give some promise that in near future we'll have more option of the therapy. Thank you.
Thank you.